to the Portland Psychedelic Society online Zoom meeting. Portland Psychedelic Society is a 501c3 nonprofit organization based here in Portland, Oregon. We are an organization dedicated to educating the public about safe uses for psychedelic medicines and different modes of consciousness. We do not condone the solicitation of substances or services here within our meetings. So please do not message each other or anyone about said substances or services. This is not the place to score. This is the place to learn and to network with your community. A couple notes about the community here in Portland and what's going on with the organization. We are developing a liaison program here at the organization. So if you are new to the Portland Psychedelic Society and this is one of your first meetings and you want a hand to hold to kind of guide you through our community and our organization and its resources, and maybe just more knowledge about psychedelics from a qualified PPS liaison, then please private message me or Jason Harris here on Zoom, or email me at evan.segura@gmail.com. I'll put my email in the chat box so people can email me. And if you're interested in becoming a liaison, you feel like you've been familiar with the organization for long enough and you want to help people become more familiar with the community and with what psychedelics are and what they could do, email me as well, because we're putting together a team of liaisons to help. On that note, if you're interested in volunteering in any capacity with the Portland Psychedelic Society, we are looking for volunteers of all abilities now until the end of the month, and are going to be holding a volunteer meeting with the board of PPS for anyone that wants to get much more involved in helping run the organization. We definitely need and appreciate your help. And so without further ado, I'm going to pass this meeting over to Dr. Matthew Hicks and Dr. Rajanna for the presentation today about ketamine and its uses in therapy. Matthew, doctors.
Thanks, Evan. And just to make a few notes, if questions come up during the course of the presentation, if you could just type those questions into the chat area, and then maybe at the end, if I don't know if Evan or Jason, you want to sort of pick the most relevant questions, and then we can address those sort of at the end. That seems to work better than people just sort of verbally throwing questions out at the end. Does that sound good? You guys?
That sounds great. Yeah, and just to clarify with everyone, so there's going to be a presentation, and then there's going to be probably the last 30 minutes or so is going to be open for Q&A.
Okay. And I need permission to do a screen share here. But while we're getting that set up, oh, here we go. Yep. Okay. Then, so yeah, I'm Dr. Matthew Hicks. I'm a naturopathic physician here in Portland, Oregon. Focused primarily on mental health in my practice. And I'm also been following the sort of psychedelic movement for a while now, and I'm in the psychedelic training program at the California Institute of Integral Studies, which is how I met Bavya. Have a quick intro.
Yes, hi. I'm Dr. Bavya Rajanna. I am an internal medicine physician, and I practice in Massachusetts. And I got interested in mental health and psychedelic-assisted psychotherapy in the course of the last couple of years. And I'm also doing the training program with Matthew at California Institute of Integral Sciences Studies.
Cool. All right. So We're going to talk a little bit about the history of ketamine. So back in the 1920s, the Park Davis Pharmaceutical Company was looking to create a new anesthetic, which was desperately needed at that time. And they discovered this family of compounds called the aryl cyclohexylamines. And the first useful one they found was phencyclidine, which was made in 1926, patented in 1953. And that was used for a while, but it had this undesirable side effect of causing hallucinations. And so it kind of fell out of favor for that reason, but also because of the hallucinations, it became a drug of abuse known as angel dust or PCP. So the search continued, and in 1962, a chemist named Calvin Stevens discovered ketamine, and shortly thereafter, a clinical researcher by the name of Edward Domino started doing clinical research with it, and he noticed all of its properties, the anesthetic as well as the analgesic, the antidepressant, and the hallucination properties that it seemed to have. But because they weren't looking for anything other than an anesthetic, they sort of kept the effects somewhat quiet, and actually needed to create a new term for it because they didn't want any association with the so-called psychotomimetics at the time, anything that had any psychedelic properties. And so it was actually Domino's wife, Antoinette, who came up with the term dissociative anesthetic. And then it got FDA approved. And where it really hit the ground running was in the Vietnam War. Became known as the buddy drug because a medic or corpsman could just kind of keep it in their pack. Someone gets injured, it was just a quick jab in a muscular area, and they, had some anesthesia. And so it got very popular during that time. In 1970, it got approved for use in children, and right now it's considered one of the UN, the WHO, the World Health Organization, considered it an essential medicine. So it's very popular throughout the world in every hospital. But as it became more popular, we kept noticing that it had this sort of antidepressant effect. And so in the late 90s, the National Institute of Mental Health did a series of studies exploring it for its antidepressant effect. But again, they saw the sort of psychedelic effect that it has as an undesirable side effect. And so they kind of were looking for a dosage range to avoid that. But they found that it was effective in treating depression. But it never quite took off, partly because it was off patent by that point. And so there was no financial incentive to continue doing this research and getting it approved for that indication. So research just sort of stopped, but it didn't stop being used for that purpose. And so since then, there has been sort of springing up all over the country these kind of ketamine clinics that are using it off-label to treat depression. But it's most of them are largely just IV clinics where people go in, they get an infusion, they kind of just sit in a chair for a while, get the infusion, and their depression will go away for about a week at a time, usually. And then they just kind of come back for treatments. But ketamine also can be seen as a drug of abuse, sometimes known as Special K. And so that's where it has sort of a negative connotation. And so it's been sort of this middle ground for a long time until more recently, partly due to the popularity of all the psychedelic research being done on other psychedelics. People have been saying, hey, what about ketamine? And that has kind of propelled it forward and more recently. And then we'll talk a little bit more about Spravato later, but in 2019 it got FDA approved for the treatment of treatment-resistant depression, and I'll talk about that more later. So it's just becoming more and more popular.
Great, thanks, Matthew. So let's look at the pharmacology of ketamine, about how it's administered and what doses. And sort of what it does in the body and how it's metabolized and excreted. All right, that's the chemical structure of ketamine, but we don't have to go too much into detail about that. So there's various different routes of administration of ketamine. The most popular ones, at least until recently, were intravenous and intramuscular. And a lot of intranasal and oral preparations have come around. When we talk about the absorption or like how ketamine acts in the body, there is this term of bioavailability that we have to understand. It simply means the amount of drug that is available at the intended site of action. And because intravenous doses, ketamine is directly administered into the bloodstream, the absorption and bioavailability with that route is 100%. When we give it intramuscularly, the action becomes a little slower because it gets some time to get into the bloodstream, and some of it gets spilled away in the muscle. So we have about 93% absorption and bioavailability. That goes down drastically when we give ketamine intranasally or orally, because oral routes, generally the drug enters the liver, it undergoes metabolism in the liver, and only some of it will get to the site that it's supposed to go to. So with oral or sublingual administration, there's about 17 to 30% of the drug that's available. And with intranasal, it's a little more than that. It's about 25 to 50%. Both of them have action starting at around 10 minutes. Oral ketamine takes a little bit longer. And so let's go look at what ketamine does. Ketamine actually acts on multiple receptors in the nervous system, and the actual mechanism of action for depression is still not very clearly understood. There's several different receptors like dopamine, serotonin, GABA, opioid, cannabinoid, nitric oxide, and others, but the most significant effect that has been found so far, about 85%, is on these N-methyl-D-aspartate receptors, or the NMDA receptors. These are the most abundant receptors present in the central nervous system, and they act as receptors for an excitatory neurotransmitter called the glutamate. It's present in about 80% of neurons in the body. It's the most common, the most abundantly available excitatory neurotransmitter. By excitatory, I mean it acts on the neuron, and the neuron gets excited, conducts the signal, takes it to the next neuron or the muscle, and so on and so forth. Now, logistically speaking, ketamine. So what ketamine does is actually go and sit on this NMDA receptor and block glutamate from acting on that neuron. So it inhibits these neurons. But when you think about it logically, glutamate is excitatory, and when it's blocked, it inhibits. So how does ketamine actually have a euphoric effect on the mood, right? This is where it gets a little bit more complex, and I hope I'm gonna make it clear for you guys. Every excitatory neuron also has some kind of upper level regulatory system that makes sure that this excitatory effect is in check. So what ketamine does is it blocks the NMDA receptors of the regulatory neurons, the inhibitory neurons. So that inhibition, that control, that regulation is taken away. So this excitation kind of happens at a quicker level and at a more robust level. And that's why as soon as we give ketamine, within a couple hours, your mood elevates and you sort of start feeling euphoric. It is metabolized in the liver, it's excreted in the urine. We can find out both ketamine and its metabolites, active metabolites in the urine. Stays in the system for about 24 hours, after which it is completely eliminated. And now to Matthew.
All right. We'll talk about a little bit what goes on in the brain from imaging studies. The first thing to mention is electroencephalography, which you can see in this sort of drawing here. Is where they attach all these electrodes and they see what sort of brainwave patterns are light up or change under the influence of ketamine. And what they found was that there's a 3 to 4-fold increase in theta waves. And theta waves are also associated with meditative states and hypnosis. And we see also an increase, about 1.5 to 2 times increase in the delta waves, which are very important for neuroendocrine functions, and that's also a more dominant brainwave that's active during sleep. So you have sort of some of those important brainwaves going on under the influence of ketamine. Now, as Bavya mentioned, glutamate is the most abundant neurotransmitter, and those receptors are the most abundant in the nervous system. So a lot of different regions in the brain are involved, potentially, in the role of ketamine and how it interacts. So it's a little bit difficult to synthesize what is the most relevant in terms of trying to understand its sort of psychedelic or antidepressant effects. But this is the simplest we can make it, or the most prominent effects that we have in the literature to sort of speculate on it. And what we notice is that there's this subgenual anterior cingulate cortex. Let me see if I can make this little pointer go here. So that's this region right here. So we have more effects from ketamine going on there, as well as the posterior cingulate cortex, which is this region here, and the prefrontal cortex, which is sort of this area in here, and as well as the hippocampus. Now the subgenual anterior cingulate cortex, again this area, seems to be more has more activity in it in the brains of people who are depressed. And so one of the theories of ketamine's antidepressant effect is that it kind of quiets down this region, which also correlates with the degree of dissociation people experience under the influence of ketamine. So it has other effects too, which if you followed the sort of research and the science behind other serotonergic-based classic psychedelics like psilocybin, LSD, you've probably heard about the default mode network and how the default mode network is what gives us sort of our sense of self. It also provides sort of mental time travel. So thinking about the past, worrying about the future, those sort of things, which can become overactive and sort of rigid in our thought patterns for someone who's depressed or anxious or obsessive compulsive or whatnot. Ketamine also helps quiet down this region of the brain and that connection between these two regions. And the same can be said for the pregenual anterior cingulate cortex and the dorsal posterior cingulate cortex as well, which are also involved in the self-monitoring that's going on. And ketamine also seems to have a positive effect on the reward circuitry. So like the dopamine circuitry in the brain, which can also be dampened in the case of depression. So what are the sort of implications here? All this stuff is very complex and we don't know concretely exactly how ketamine has its antidepressant effects, but these are some theories. One is basically what I've already said, in that it increases interconnectivity of the cortical and limbic systems. So I mentioned those other regions where it quiets them down, where they become very sort of rigid. When we quiet those self-monitoring regions of our brain, it allows other regions to kind of cross-connect in ways that they're normally inhibited. So now they're uninhibited and they can talk to each other. So when we talk about the cortex, particularly the frontal cortex, being able to talk and interact with the limbic system, the frontal cortex being more cognitive thought type stuff, the limbic system being generally more emotional, we're able to have some new material that we're able to experience under the influence. The other sort of theory that we have with ketamine, its antidepressant effect, is called this glutamate surge hypothesis, where we have found that in the case of major depression, there's increased glutamate, particularly in the dorsolateral prefrontal cortex, the dorsal medial prefrontal cortex, and the anterior cingulate cortex. And so by blocking those glutamate receptors, so we block them, a bunch of glutamate basically builds up because it doesn't have anywhere to bind to. It also gets upregulated, so we start producing more glutamate. And then when those glutamate receptors become available again, when the ketamine dissipates, you get a surge, and so you actually get more glutamate interacting with those glutamate receptors and NMDR receptors. So that might be a potential mechanism by which it has its antidepressant effects. But some studies have had difficulty validating that, so we don't 100% know that for sure. So Barb's going to talk about some more medical considerations.
So far, we learned about how ketamine was made and what it does in the body on a molecular level and at the neurological, at the brain level. Now, if we want to use ketamine on people, how do we do it? What should we consider? Patient-specific characteristics, the medication itself, how safe it is, and what are its side effects and other things. So we'll review that in this section. It has been around for 50 odd years. Ketamine is one of the most widely used drugs in the world. It has, we have used that as an anesthetic, we still do. We use that for chronic pain. It's very common for people with chronic refractory pain to go to the hospital and have ketamine infusions done for up to 5 days continuously IV. We've used that in as buddy drug. And the reason it's actually buddy drug in the war, it's really cool. Ketamine, while being a very strong anesthetic and analgesic, does not cause any respiratory depression. So the soldiers, even with little medical training, can safely administer this medication knowing that their co-soldiers will not die from respiratory arrest by giving ketamine. So it's a pretty safe drug. They've studied it over prolonged periods of time, and they have not really noticed any serious life-threatening side effects from it. Some transient side effects that do resolve quickly and on their own include a transient increase in blood pressure while giving the medication. There can be some dissociative effects because it's a psychedelic. There is some bladder inflammation that is actually pretty common with prolonged use, but that also resolves very quickly. Bladder inflammation can lead to UTIs. There can be some transient increase in liver enzymes, but again, that resolves on its own. It doesn't really cause hepatitis or chronic injuries to the liver. There have been, I think, 1, maybe 2 case reports about people that are abusing ketamine for prolonged periods of time, like every hour, on the hour for 48 to 72 hours, taking significantly higher doses than psychedelic or anesthetic doses that have had cystitis, that is a bladder inflammation that has been irreversible and requiring surgical intervention. But I think that's just about 2 case reports in all these years of using ketamine. So it is a pretty safe drug. Now, let's look at the logistics of it. So it is Schedule 3, and that's good because all the other psychedelics that are being tried and tested now for psychotherapy all belong to Schedule 1. So anybody with the DEA license can prescribe this medication. And because it has been around for so long and it's off patent, it's pretty cheap. But just because it is pretty cheap doesn't make it any cheaper to do the treatment with it, because FDA still has not approved racemic ketamine, that's the ketamine that's available for depression. It's still used only for anesthesia. So if we want to use it for depression, it's an off-label use, and insurance companies unfortunately do not approve any medications that are used for off-label. That makes it only cash payable and makes it inaccessible for people. That's one. Otherwise, I think it's safe. Side effect profile is pretty good. So all the ketamine clinics have started springing up, and there's a lot of money to be made in this business as long as there's no approval for FDAs. But Janssen actually came up with Enantiomer of Ketamine called S-ketamine or Spravato, which Matthew will talk about now.
Yeah, so in 2019, Spravato got approved by the FDA for treatment-resistant depression. And Spravato is the brand name. S-ketamine is just ketamine. And what that means is that ketamine is a racemic molecule. That means basically there's a right and a left-handed side to it. They're mirror images of each other, just like your hands, right? And so they found that the S version of ketamine, the S-ketamine, has a stronger binding capacity for those NMDA receptors. And so they thought, hey, that's a great approach. Let's use that instead of R. Recent studies have shown that R may have stronger antidepressant effects. So, and the reason they did this is because they can patent a technique to filter it so that you only get the S version of it. So really, this is sort of Big Pharma's way of making more money off of ketamine, which has been around for a long time and is dirt cheap. Janssen, which is owned by Johnson & Johnson, fronted the money to get it approved, though. So, it is what it is. The cost is somewhere around $500 per dose, whereas a dose of regular ketamine, racemic ketamine, like a dollar, something like that. So, but you can get your insurance to cover this. That's the thing. Okay, I've already kind of said that. Your insurance providers will cover it. Their criteria for treatment-resistant depression is usually that someone has tried and failed 2 different types of antidepressants. Usually they want to see 2 different categories, so like an SSRI and maybe an atypical antipsychotic, or maybe a tricyclic antidepressant or something for a sufficient amount of time. Usually they want to see a diagnosis, sometimes by more than one professional, and they want to find any reason they can not to cover it because it's so expensive. But if you meet all their criteria, they will cover the cost of the medication. And they also want you to be on another antidepressant while you're going through the treatment. They also have you enroll in a REMS program. REMS stands for Risk Evaluation and Mitigation Strategy. There are many medications that have REMS programs. And what that means is both the provider, the pharmacy, and the patient have to enroll in a program to basically monitor the distribution of this medicine and log each dose, basically. It involves being present for 2 hours at a time in your doctor's office where you're monitored, where you get your blood pressure measured 3 times. You're not allowed to drive and things like that. On the provider side, I've been doing some Spravato, and one of my struggles with it is sort of just the financing part of it, because that 2-hour visit, I can't really bill anyone's insurance for 2 hours at a time. So I either have to do it in groups or find ways to stagger people or have extra space in my clinic. And so that's a bit of a struggle. As far as its sort of psychedelic properties, we can't really control the dose very well. Each of these little nasal sprays you see in the picture there is 24 milligrams each. And so I really only have the choice to prescribe either 56 or 84 milligrams. So that means taking either 2 or 3 of these sprays at a time. And that's as far as I can go. I can't even, it has to be delivered directly to me. A patient can't even pick this up as part of the REMS program. So there's a lot of logistical headaches with doing Spravato. But all that to say is it is, because it's covered by insurance, the positive of it is that it is helping people, and it does seem to be effective and safe. So be that as it may, that's what I've got to say about Spravato. I'm sure you'll have some questions about that. But let's talk about a little bit the different paradigms of using ketamine.
Great. So over the last 20 years, there have been close to 1,000 studies done on ketamine for ketamine for depression, and several different dose protocols and guidelines have come out. The doses range from very low, which just causes an empathogenic effect and opens up the patient to do treatment, up to a very high psychedelic dose that causes complete dissociation, and then to do therapy and integration later. So there's a wide spectrum of dosing, there's a wide spectrum of treatment protocols, there's a wide spectrum of how the ketamine practice is done all across the country. So let's look at some of them. The first one, and the most popular one, and the most commonly used one, is the pharmacological antidepressant model, which is your ketamine clinic. People come in, get their IV infusions, go back. The NIMH model, the National Institute of Mental Health model, is to first have an induction dose for major depression, which is about 4 to 6 doses spaced every 2 to 3 days, given over a 2-week period, which will have remission for depression in about a third of the patients receiving this medication. And then after, to treat based on relapse or based on continuation of symptoms, spaced every week or every 2 weeks or every month, depending on how the symptoms are and how the patients are responding to the medication. But that is that. This is only that. If you come in, you take the IV medication, you go home. There's really, it's not necessary for you to see a therapist. It's not necessary to integrate from this session. Nothing else is mandatory. So I mean, you can see that there is a lot of it kind of falls short into what we can actually do with this medication, because it is fascinating how much ketamine can do, and we kind of have a lot of room to grow from here. So the next model that came out that is increasing now in popularity is the ketamine-assisted psychotherapy model, where ketamine is considered as a tool in the psychotherapist's toolbox. It's either given in a low dose, a psycholytic dose, during a therapy session, so patients can open up. It's sort of switching on something in their brain that makes the patients kind of open up and be receptive to therapy. Or we can do the same exact thing as pharmacological model, where there's a therapist working, they do prep sessions for ketamine, go get the IV medication, and after that integrate with that and continue therapy work. They did do a study comparing this model with just giving the ketamine, and obviously there were significant differences between for remission. There were significant differences in the extent of relapse and the duration of relapse. There was normally relapse occurs between 7 days to 18 days when giving IV ketamine, and they saw relapses occur as late as 30 to like 35 days when they did this, assimilated this with psychotherapy. But ideally, we would like to go a step further than that. And really what we should be doing is kind of integrative CAP model, where we do the drug, we do psychotherapy, and along with that, we give patients other tools like mindfulness, eating healthy, exercising, a lot of other lifestyle interventions, taking your supplements, which will really promote a holistic level of healing. And this is what we are actually adopting at our organization, Synaptic Care, which we can talk about in a little bit.
Sure.
Yeah. So these are the treatment paradigms. There have been studies now to sort of use ketamine just the way other antidepressants are used, to just give very low dose ketamines, kind of just give them a 30-day prescription, have them take it every day, followed by every couple of days, and then just when you feel like your symptoms are coming on. And that's catching on because it is in a lot of ways cost effective. And once we finish the induction stage, once we actually get those patients into remission, we can maintain those patients on remission with doing this low dose. But there's still more studies and more data that's coming out. And that's our talk.
That's basically it.
Yeah.
I'm sure we have some questions. As Bavya mentioned, we are starting a clinic here in Portland called Synaptic. We have a website that we'll be offering ketamine-assisted psychotherapy, and also have a podcast called Integrative Psychiatry Review, if you want to check that out. But yeah, at this time, if we have some questions, Jason or Evan, if you want to sort of read those to us, we'll be happy to answer them best we can.
Okay. Bilirubin. No, it does not affect bilirubin levels. It gets metabolized by the CYP enzyme system. So people with hepatitis, of course, I think that it may take longer to metabolize, and the active metabolites will maybe like stay in the system for a longer period of time, and there may be some dose adjustment for such folks. If people are chronic alcoholics, that is another thing to consider, because that will also have an effect on the liver. You may not have chronic hepatitis, you may not have liver enzyme elevation as yet, but if you are on certain medications that get metabolized in the liver with the same enzyme system, or if you're chronic alcoholics, then we'll have to sort of look at that and adjust the dose accordingly. Sure. Yeah.
Yeah, well, that's really a dosing question. Ketamine does have very different effects based on how it's dosed. Sounds like that was probably a pretty heavy one, because remember, this is the same anesthetic that we use to knock people out completely for surgeries and stuff. So the psychedelic dose is lower than that, but in the sub-anesthetic dose, that's where there's the wiggle room, where a real light dose is sort of empathogenic, but people are still very, cognitively aware of their experience. And then as you get it closer and closer to anesthetic, that's where it gets kind of trippy and you know, psychedelic. But beyond a certain threshold, yeah, you would sort of you know, potentially lose some of those senses.
And also to remember that there is, we were talking about it earlier, the only way we can predict the effects are when we are giving IV, because if we know that the patient is about to lose senses, we can stop the drip, and then, you know, that the effects will become lesser. But when we give intranasal or oral or IM, we're actually giving the whole dose already. So we cannot actually predict how much of the sensation is lost and where they fall under. So the best we can do is sit with them, knowing that it is safe, it's okay. There will likely not be any respiratory or cardiac effects from it. And if it's really getting out of hand, please call 911. And if it's not getting that much out of hand, but if you're just losing some senses, and if you are afraid that you may stop breathing, you can try laying on your left side, because that will kind of help with breathing a little bit, and your heart, it supports your heart as well. Other than that, just have someone as a designated sitter that is able to like identify if you're having a bad trip and support you.
Yeah, so there's different protocols in that regard, and it depends on the prescriber and what their approach is. It can be sent to like a compounding pharmacy, and you can just pick up a lozenge. That's one way to do it. But usually the model that we're going to follow, and the one that is mostly used for ketamine-assisted psychotherapy, is you come into the clinic, you have it administered by the clinician, and you're doing the therapy there. And it's, you know, it can range, the experiences, it kind of peaks around 20 to 40 minutes, and then you're pretty sobered up at about the 2-hour mark usually. And then, and so depending on the model, like Bavya talked about, there's the cyclic where you're engaging in therapy during that time. That's a lower dose, or the more psychedelic dose, you're not really doing the therapy then, but we'll have like an integration session like the day after. But not so much not at home. It's a controlled substance, right? So it requires some supervision from the clinician. I haven't seen anything about
really.
that.
No, it doesn't. It mainly acts on the sodium and calcium channels, like the glutamate receptor, the way it acts. We really want to get into the nitty-gritty stuff. Not so much the potassium now, so it shouldn't.
Well, its duration of effect is much shorter. It seems to be really effective for about 6 days, and then often depression will come back. Compare that to like the psilocybin study, where you get like 6 months of it. So, but it's also, you know, that's just speaking of the depression part of it. That's part of the reason we're pairing it with therapy and doing the ketamine-assisted psychotherapy, because depression it's a complex disease, really, and it can be, for some people, existential, and for some people it's more neurological. You know, and trying to find where that is on the continuum is going to be very individual. And so by ketamine having a pharmacologic effect, we're addressing it that way, and it can be very rapid acting. But by pairing it with psychotherapy, which in the case of psilocybin, I think it certainly has the pharmacologic antidepressant experience effect of it. But I think that research indicates that it's really the mystical experience, the experience of the therapy, that is really the sort of healing component of it. So when I say that ketamine is very short acting, I'm speaking for most of the research we have on it. It is just that pharmacologic model we talked about, where people are just relying on the drug to sort of fix the depression, and that effect seems to work, for roughly a week at a time. But by dealing with underlying issues and kind of getting at the core of the cause of the depression, we hope to get longer periods of remission.
And also with psychedelics, a lot of people use it for recreational purposes, and those may not necessarily result in an antidepressant or changing your fundamental state of mind sort of effect, right? So integration is most important. So be it ketamine, be it psilocybin, or be it any other psychedelic, I think the focus is more on integrating and the psychotherapy aspect of it. Ketamine is short acting, but it is available today to treat. Psilocybin is not, and that makes a lot of difference too.
Yeah, that's actually one of the advantages of ketamine over some of the other psychedelic studies, or the other psychedelic substances, because with the serotonergic psychedelics, which is the primary mechanism by which they act, there's a real concern of triggering a manic episode with them. We don't have that same risk with ketamine because its mechanism is so different. So I certainly would shy away from doing ketamine with someone if they were currently in a manic phase, but we don't have that same level of risk. So it's not a contraindication in the case of doing ketamine. So that is an advantage of ketamine over these other methods.
Yeah, they have actually done studies on bipolar 1 with ketamine, and they have found good results with it. I think that came out in 2015 or 2016. It was a small number, so it wasn't really well validated, but the outcomes of these studies have been positive overall.
Oregon Health Plan, yes, Medicaid, and they will cover Spravato if you meet the criteria for treatment-resistant depression. They can, but they might there might be some hoops to jump through with that, because they really want you to try something cheaper first. But yeah, if you find a clinician who takes it, who does Spravato, then you might be able to do it that way. But doing ketamine-assisted psychotherapy using that model, probably not, because it's off-label. Insurance does not cover it. Even though the medication is so cheap, what you're paying for in that therapy is clinician time, and because it's off-label, an off-label use, even if a clinician takes OHP or Medicaid, they're doing an off-label treatment, so insurance won't cover it, and so that's why they're all cash-based.
Can I interject?
Sure.
So what do you think the average cost is for a supply of it for a week or so? Like, because I know I take about 6 pills, and one of them is like $400 out of pocket for like 2 weeks supply. What do you think the average cost cost would be for like if you're just paying cash out of pocket? Do you know?
Well, just for the ketamine itself, like if you're getting it from like a compounding pharmacy, and you're just taking a pill, then it's again that's still not super expensive, but you're not getting the full therapy with it. And
Mm-hmm.
it depends on the dose and the cost of the compounding pharmacy. But I was doing Spravato with a few patients when the quarantine hit, and so we decided not to continue doing that in person. And so what I actually did with a few patients was switch them temporarily to just prescribing them compounded ketamine lozenges, where they could just get it delivered from the compounding pharmacy to their home. And we were doing it, twice a week, which is the same protocol as Spravato at a somewhat comparable dose. And I think for a month's supply, they were paying somewhere between $40 to $60.
Oh, that's good.
So not too expensive doing it that way.
Mm-hmm.
But again, you're sort of just getting a pill.
Right. It's exactly the same thing. And again, we have to understand that even in treatment-resistant depression patients, the remission rates are like about a third of patients achieve remission with depression. So it's still a struggle. So we really have to sort of like look at it from what else it can do, because the SSRIs or the traditional antidepressants that we are using also have the same amount of remission rates. Like a third of them get better and stay better. Even in ketamine, a third of them get better and stay better. So if you look at that, it's just alone, the comparison, it compares with any other antidepressant. But when you kind of add all of these modalities like psychotherapy and integration and all of that, that's when you see the real difference. Mm-hmm. And I think that's the value. Instead of taking ketamine as, a pill, okay, like I'm going to go to the pharmacy and get a pill.
Yeah, I agree. I'm a yoga teacher and practiced meditation for over 2 decades. Mm-hmm. So I try to combine all of these things together to create the whole, as you guys know, naturopathic doctors. So thank you for your answer. I appreciate it.
Sure.
Well, I will be offering it. So the Oregon Naturopathic Board made a kind of a silly rule and decided that naturopaths can't do it by injection. We can do other injections, but they decided they don't want us injecting ketamine, but we can do nasal ketamine, which really, the silly thing about that is it just takes away clear dosing. Mm-hmm. So it's sort of a funny thing, but I'll be offering that here probably next month in Portland. Yeah. So it kind of depends on the type of therapy we want to do. Again, the psycholytic, where we're engaging in therapy during the ketamine experience, or if we want a higher dose, which is more psychedelic, in which case we'll do an integration session like the day after. And then because nasal, the absorption rate varies. It's anywhere between 25 to 50% of the medicine actually makes it into your system. So it might take, a few sessions to sort of figure out what your individual absorption rate is to see if we get the dose that we want, which is the advantage of doing IV, because it's 100% absorption. We can just say, 2 milligrams per kilogram dosage range based on your body weight, and we can kind of get where we want more clearly. But doing nasal spray, it still works. It's still very effective. I know plenty of people who've done it. So that's what we'll be doing. But it'll be on a case-by-case basis. It's not we're not doing an exact cookie cutter method. The general protocol that we'll be using is basically medical intake, kind of screen you, make sure we have a clear diagnosis. Then 2 preparatory sessions, which are more about creating a kind of a therapeutic relationship where I really get to know you and what the issues are and what might come up. And then we have the ketamine sessions, which we're going to have a minimum of 2. If we're going to engage in it, we need a minimum of 2, and really 3 is better. And then each of those has to be followed with an integration session afterwards. And then after we go through that protocol, we can add more sessions as needed. But part of the importance of the prep sessions is to understand some of the material that can come up. What I hear over and over again from people who are doing this work is that often what comes up is a lot of trauma. Sometimes trauma that people aren't prepared for. They think, well, I'm just depressed. And then they get in an altered state and they remember they were abused as a child and it had been a memory they were repressing. Or they know what their traumas are, but they aren't prepared for the full experience of it. Or you know, they can have different levels of insight about what might come up. And so being prepared both as the clinician as well as the patient being prepared and having a trusting therapeutic alliance between the 2 of us is really important. So that's our general protocol. But like I said, it's there might be some wiggle room based on individual needs. And I'm also doing kind of my full integrative mental health approaches too. So I'll talk about, you know, diet and exercise and lifestyle and supplements and medication management and all those things. Microdosing with ketamine?
I think nasal paste. Is the nasal paste even available as a
Well,
prescription?
Well, I mean, if you're talking about like street ketamine, usually it's most commonly a powder.
Yeah.
Which I don't know. I actually had someone who asked me. They wanted me to just prescribe it in small doses because one of the things we didn't mention in our presentation is that ketamine promotes neurogenesis. So it's actually increases neuroplasticity of your brain, which is it increases BDNF. Is sort of the mechanism of that. So it's good for your brain, and that's also another factor in its antidepressant effect. And he was like, "Hey, I want to live longer. And will you prescribe me ketamine?" And I told him no, ultimately. Although theoretically that actually sounds great, and we should give everyone low-dose ketamine potentially for that reason. But I didn't feel comfortable doing that. There's not. I mean, what I just said is evidence-based in terms of its neurogenic effects, but there's like 0 clinical trials on prolonging life that I know of. Use it long-term ketamine exposure. I mean, we know a little bit about some of the harms with chronic abuse of ketamine, but not long-term use for therapeutic reasons. So it's just sort of an unknown right now. I don't know of anyone talking about microdosing ketamine. So
Yeah, there's no microdosing, but there is something called very low dose ketamine. It's like the lowest possible dose. I think but it was not given for depression. It was actually given for chronic pain. There was this physician in London, an anesthetist actually, that was treating these patients with chronic refractory pain for years and years with like all these pain modalities, and they did not improve. So he started giving them very, very low dose ketamine for that every alternate day. And he did that for about 13 years, and then he wrote a paper on it. And he saw really significant improvements, but that's only studied for pain. It's not been studied for depression. So we don't really have that data about it. I mean, I don't know. It's an interesting question, and I hope somebody can do research on microdosing ketamine.
Interesting idea.
Yeah. Yes, it is there, and they have actually found really positive results with it. So I think soon we can actually give ketamine for OCD. And also with eating disorders and addiction, and they're even talking about adding ketamine to the 12-step program, seeing how that works out. So there is definitely research on all the common mental health disorders to treat, and OCD is one of them, and they have found positive results. Yeah. Yeah, so there is with the 12-step recovery process. So the best thing about ketamine, the way that it improves neuroplasticity, like we just talked about, it's like the patients that are depressed, that are traumatized, and are dealing with PTSD and are dealing with addiction, they all have decreased neural pathways in a way. Like they can't process information like other people with like good mental health can, because they just don't have those connections. They don't have so many pathways. They don't have so many neurons that are active at the same time transmitting these signals. What ketamine does is it suddenly, within hours of being in the system, it increases those connections. Even though it leads to, we don't know if it actually leads to regeneration of a neuron, but it improves those connections immediately. So we have more connections. So suddenly there's more signaling and there's more pathways, and you kind of open up this brain, you expand what the brain can do. So if you think in those terms, you can see how far reaching the effects and the uses of it can be. So in addiction, like if people are addicted because they're depressed and they get addicted more and then they get depressed more, and it's this vicious cycle. Mm-hmm. So what ketamine does in breaking the cycle is just suddenly it opens up the signaling pathways, and people become more engaged, and people become more open, and they can actually see what is happening to them in a way that they couldn't before, because they just didn't have that brain potential to see it, and suddenly they can, and that will help them with this. So I think that's the main deal.
I don't know about prevent, but it's not, there doesn't seem to be much concern about it triggering one. So I don't know.
Potentially, I mean, it's not a mood stabilizer. Yeah. So, I mean, does it have the potential to do it at higher doses? I mean, it can, but also it's an anesthetic, so it kind of makes you go to sleep. So I'm not sure.
Yeah,
I'm not sure. Mm-hmm.
Do you mean EMDR, like the psychotherapy? Okay. Well, what kind of happens with a lot of these, and it's very similar in the different mood disorders, whether we're talking about depression, anxiety, obsessive compulsive, even addictions, eating disorders, is there's this sort of hyper functioning of that anterior cingulate cortex and the posterior cingulate cortex, and it sort of creates these loops, right? Where there's a lot greater focus on the self, because that's what those regions of the brain are doing, is they're monitoring the self, right? So if you have read Robin Carhart Harris's article about the entropic brain theory, we have what he describes as primary and secondary consciousness, right? So when we're developing somewhere, we kind of start in this primary state of consciousness where we're aware of stuff, we have sensations happening, but we don't necessarily understand how we're separate from them, right? We don't really know that we're separate from our mother inside whom we are developing. And then eventually we're born and we understand, at some point we learn that we're separate from our mother, we're separate from other objects. And that is because our senses, touch, taste, smell, all those things, they come into the cortex and they provide the senses. And these regions that become hyperactive or around self-awareness are the ones that basically say, it's me sitting in this chair. And when I'm hungry, I have to put food in my mouth, and so on and so forth. But when those regions get overactive, we think about ourselves too much. We worry about the mistakes we made in the past. We're really worried about the future. We're really upset that we screwed up and we did meth again, or we binged and purged again, or we checked make sure the oven was off 20 times today. Those systems are overactive. And so what ketamine and as well as the other psychedelics do is they quiet that region down. And so, and if you've ever had a psychedelic experience, your sense of self kind of dissolves, right? And you feel more at one with everything, right? Where the self doesn't matter as much. And so, and what that also enables to happen is our different senses cross-connect. This is called synesthesia, where sometimes a smell has a color and a taste has a touch to it. You have these sort of, your brain is interacting in ways it doesn't normally interact, and that's sort of the mystical experience. And it's sort of a way of saying, oh, there's a different way to experience the world and experience my different senses. And so we can integrate those experiences and say, oh, this thing I've been thinking about and obsessing over and struggling with, that doesn't have to be my story. It can actually be something else. And so we have sort of the experience of it, but also the neurological things going on that are sort of a rebirth, a renewal. I mean, you're literally growing new brain cells and new brain neuron connections, but you're also having an experience that is telling you can construct a different story. And so that's sort of the mechanism by which these things can do their most powerful work.
That's a great question. It's a great question because I think when ketamine started becoming popular for depression, this is exactly the question that everyone wanted answers for. Oh my God, can I get off my SSRIs? Can I just get like these 6 infusions of ketamine in 2 weeks and get off these meds? And after that, just use ketamine as and when I need, maybe once a month or twice a month, and I never have to be on this pill that I take daily all the time, right? The short answer from what we know until today is no. The long answer is it really depends on how well you actually respond to ketamine, and then your clinician and you can sort of look at your symptoms and how you're doing and how often your relapses are and like what your symptom profile is, and then decide that together.
You don't have to be off your medications to do ketamine, right, because they don't interact. So that's an advantage. You can kind of see how well you do with ketamine. Maybe you see some improvement, and you want to cut back or taper down on your other antidepressants. But that's always going to be a case by case basis and a sort of a negotiation between you and your clinician. Yeah, it's a tough one.
Yeah.
You know, and it's one that we're, I mean, I feel
You're struggling.
I grew up for it. Like, I get it. It's a struggle. I mean, we have to pay the rent, you know, so we have to charge something, right, for what we do. And I wish we had better ways to make it more accessible. I wish we had universal health care. So, you know, both, but that's a long-term solution, right? Not a short-term solution. What do we do right now?
I wish FDA just looked at all these studies for the last 20 years and just approved ketamine.
Right.
And that way we could just get this drug for 50 cents and it will be available for everybody.
Yeah. Yeah, unfortunately, the way the FDA is funded through drug applications, and they just don't seem to do stuff unless there's an organization pushing research to do it for a specific indication, like MAPS is doing with MDMA, right, or Big Pharma does with any medication. But yeah, you know, one of the intentions we have with Synaptic is we're offering a sliding scale. Where we have sort of a price range. And for those who are able to pay full price, we're going to set aside a portion of it and create a scholarship fund for people, underserved communities that can access it. But, you know, that's going to be a limited basis. I imagine we'll have to probably have a wait list for people who, you know, meet that criteria and do it, because we just can't. We can't offer it to everybody. Yeah, I wish I had a better answer, but that's just sort of that's the world we live in right now. Well, right now on our website we have a place where you can enter your email address, and we'll have some announcements coming up soon. And we'll blast that out to that email list when we're set up. Right now, we're looking for a location, so that's sort of the next big step. And once we have a location settled, we'll start offering services soon. In fact, right now you can even schedule a 15-minute consult. I'll do a 15-minute free consult with you just to see if you know, we might be a good match, and from there we can start schedule. We can actually do some of the preliminary work relatively soon, you know, the intake and the sort of prep sessions, so that when we do have a location, we can start doing you know, the actual ketamine sessions in person, and we'll be ready to go.
Hello, can you hear me? I've probably used this as an anesthesiologist. I've probably used it like 20 or 30,000 times, typically with other anesthetics though, and not always, but often is an upfront dose with no other pre-medication. So I can say that's not correct. And hence was my other question regarding your dose, because there's an incredible difference in the way people respond. For instance, I can give 25 milligrams IV and have someone totally, like, you know, almost out, or I could give some people almost 100 milligrams and have them talk and say, wow, this is really cool. And it's really remarkable. And so that brings up an interesting question about dosing, which I had asked, and that was, on an incremental basis during therapy? And also, do you note that for future therapy, like, hey, this person needed 2 mg per kg versus this person got by with 20, a half milligram per kilo. Anyway, but to answer that question, no, it's not. That's not an accurate portrayal of ketamine use.
And to that question, I think most of the most standard dose protocols are right now at 0.5 mg per kg, and that's the first dose. And depending on how people react to the first dose, I think further dosages are sort of either decreased or increased. But everybody usually starts off with 0.5 mg per kg given over 40 minutes.
Okay, yeah, thank you for answering that too. I appreciate it.
Yeah, of course. Yeah, I mean, so ketamine is a dissociative psychedelic, right? And mushrooms and LSD are all classic psychedelics. So ketamine has this out of body or the dissolution of self component to it that is more profound than what you have with this classic psychedelics. Other than that, it's more sterile, I hear some people say.
Yeah,
the colors and the visuals.
Yeah, it can be less
Yeah,
visual.
less visual.
In the fMRI studies with LSD and psilocybin, they find that the occipital lobe of the brain really lights up. So in the eyes closed state, so you're seeing colors and geometric shapes and whatnot. You're really seeing a lot. Ketamine, not so much. So it's less visual, which doesn't mean it's not trippy. It's just less visually stimulating. But yeah, I mean, all of these substances, even ones with very similar mechanisms, have sort of different experiences.
Right.
But how, other than what we've said about ketamine, that's about as much as I know.
Yes.
Well, I mean, yeah, I mean, my hunch is, if I understand the question correctly, it's basically a yes. I don't know how well we can precisely say yes to that. I mean, it's sort of theoretical at that point. But we do know we have new brain cell growth under the influence of ketamine going on. And, like I explained with sort of the experiential component with, the sense of self sort of muted and allowing other experiences to come in and doing the integration therapy around our thought patterns and whatnot. We have sort of the neurological growth is happening, but also the sort of psychological, emotional, spiritual growth that is possible. So you are in a way sort of reprogramming, something new potentially. I think, I don't know if that answers that question, but that's my stab at it.
Yes, I did just want to ask Dr. Rajanna, when she was comparing ketamine with the other psychedelics, I think she said she thought ketamine was more profound. And I wanted to ask her to expound on what she meant by the word.
Um,
Did I get that wrong?
yeah, right. Because it's a dissociative anesthetic. So at moderate to high doses, you sort of have this out of body experience, and I mean that's commonly referred to as the K hole. So you kind of go into the K hole and you lose your sense of self, and that is less common, or I think less so observed in other classic psychedelics like LSD or mushrooms. You're still even if you're having visuals, you're kind of still aware of where you are, in a sense that you're not with ketamine when you get to that moderate to high doses, because you do lose your sense of self. That's ego dissolution. I hope I answered the question.
That reminds me of a quote from Timothy Leary and Richard Albert's introduction to Alan Watts's book, where they say the leap across entangling thickets of the verbal to identify with the totality of the experienced is a phenomenon reported over and over by these persons. Is that the kind of experience you're talking about?
Not sure I understand.
I'm not sure. I'm sorry. I think your volume is a little low and we're not able to hear you.
The quote that they were from the book, that they were talking about different studies, saying of the subjects who took the drugs, quote, the leap across entangling thickets of the verbal to identify with the totality of the experienced is a phenomenon reported over and over by these persons.
Yeah, I mean that's sort of the connection with the numinous that we see in all these psychedelics, and the difficulty in expressing them verbally, right? Because they're such a deeply felt experience, and that's from what I've heard, and this is sort of just reports, anecdotal sort of stuff, but some people would say ketamine is the most spiritual experience they've had, even over some of the other classic psychedelics. I mean, that's very subjective, right? But I've heard that from more than one source. So take it for what it's worth.
Sure. Thanks for that. Thank you.
Thank you for your time.
Thank you.
Thank you.
Bye.